So we are still talking about fistulas, but for this very slide of video, we are going to look at the rectovaginal fistula. Still Modrik's is my name. I'm a registered nurse. And that is the YouTube channel that you can share to your colleague to get all this information. So when you talk about rectovaginal fistula, the word recto comes from rectum. Vaginal, that's the vaginal fistula. We say that's an abnormal communication. So rectovaginal fistula is an abnormal communication between the rectum and the vagina. So for this very slide of video, we are going to look at the definition, as I've already said, then the risk factors, and also the treatment of rectovaginal fistula. So rectovaginal fistula, sometimes they are congenital, sometimes they are acquired, but you are saying it's an abnormal communication between the vagina and the rectum, and this results in involuntary escape of flatus or stool or both. Because of this abnormal communication, there is escape of flatus, stool, or both. Risk factors to rectovaginal fistula, one of them is 3rd or 4th degree perineal tear. Most mothers who get this 3rd or 4th degree perineal tear can end up having a rectovaginal fistula. Then we talk about an unrecognized vaginal laceration during operation. If the mother is being operated on and there is a laceration that I have not recognized, it can end up making a rectovaginal fistula. Then there is Crohn's disease, which means inflammatory bowel disease. And once the bowel is inflamed, then it can end up having perforations or overpressing on the mass that separates the vagina and the rectum, and hence rectovaginal fistula. Then there's also colitis, which is the inflammation of the colon, can also eventually lead to a rectovaginal fistula. Then we are still continuing some risk factors, which is infection like cryptoglandular abscess. This can eventually rupture, or the tissue that has an abscess can eventually rupture and someone ends up with a rectovaginal fistula. Then there is lymphogranuloma, venereum, infection like TB, Bartholin's abscess, human papillomavirus, and diverticular diseases. All these are risk factors that can eventually lead to a rectovaginal fistula. So we are saying there should another risk factor is previous history of surgery, especially in the anorectal area. It's also a risk factor. For example, if they were done hemorrhoidectomy, lower anterior resection, these are the surgeries that can be done and ends up leading to a rectovaginal fistula. The excision of the rectal tumors, hysterectomy, there is posterior vaginal repair. These other surgeries can eventually lead to a rectovaginal fistula. How do we treat someone who has a rectovaginal fistula? We are saying that treatment will depend on underlying cause, the size and the location of the fistula. So some women with small rectovaginal fistula following obstetrical trauma may be followed conservatively or may be treated conservatively, and they can heal spontaneously without any repair if the fistula is small, as we saw even in the previous video. But larger obstetrical fistulas, what do? Most times we need to do a surgical procedure to see that we repair this fistula. And here we are going to do posterior colporophy to see that we repair these fistulas. Then you are looking at the IV fluids. Imagine the mother has been leaking stool for all along. We need to replace those fluids that were coming from that stool that couldn't be kept, and We can also look at the enema, especially this is done before operation. We ensure that the gut is completely empty so that the incision site or the operation site should not be affected, should not have sepsis postoperatively. Surgical techniques that can be used to repair rectovaginal fistula. There is a transverse vaginal or transannual approach. Transvaginal, they pass through the vagina to do operation. Transannual, pass in the rectum to do the operation, like episioprototomy. They can also do a fistulotomy, and all these procedures, doctors will do them to repair the fistula. Still with surgical repair, we're saying should be delayed until the surrounding tissue is free from edema. This is something to note. If the surrounding tissue have edema, please let us delay the surgery. Most times we are saying mid-level vaginal fistulas are also often due to obstetric autonomy. This is more information that you need to know about rectovaginal fistula, that high fistulas are most commonly repaired by a transabdominal approach. If the fistula is high, like how we saw when we are diagnosing, we shall find that we can operate on the abdomen to work on this fistula. Thank you so much. That marks the end of all the fistulas that we need to look at: vesicovaginal fistula and also rectovaginal fistula. Any question is still welcomed. Subscribe to the YouTube channel and share it with a colleague, and also ask your question in a comment box. Thank you.